Quite. Are you awake? Yes. Enjoy your lunch. Yes. Had some coffee. It's a dangerous time of day after the lunch and the blood sugar. Okay, so I will try to keep you awake. Now I will give you some input again, and then we will have a new exercise. Okay. Okay. So in the start of today's session, Jürgen and I said that one of the key elements in our approach to shared decision making is that it's not only between the physicians and the patients. Even though it was very much so many years ago in many places, we see now that there is much more acknowledgement of other healthcare professionals as well. Because it's important that nurses, physiotherapists, occupational therapists, and other kinds of healthcare professionals can also contribute to the SDM process. So these 6 steps can be divided between different kinds of healthcare professionals. And I know that there are quite some nurses here today, and we also gave a lecture on the nurses' role in shared decision making the day we arrived. So now I'm a little bit back to this. So what is a decision coach? A decision coach is a trained healthcare professional. He's trained to support patients and relatives facing decisions, health or social decisions, to make an informed choice or prepare them to actively participate in decisions. So, and what is the difference between those two? So the nurse or decision coach can make the entire decision process a shared decision making with the patient. He can prepare the patient to make the final decision with the physician. He can also support and prepare the patient to make an informed choice by themselves. Maybe they don't need a shared decision, right? So how is this coaching provided? Often it is provided in person, but it could also be provided by phone. Such as to give you an example, 2 weeks ago, I had a whole day training session with oncology nurses working on the cancer line. It's a phone line patients can call, patients and relatives, when they have asked questions about their treatment or their relatives' treatment about cancer. And then the nurses take the phone and they can do the decision coaching with the patients. Okay, so what does this coaching entail? It can be done in various ways, and it depends on the type of health issue, also medical problem, the patient is facing, and also, of course, the healthcare professional, the coach's competencies. Is he really a trained decision coach? And also the division between how you split the responsibility within the team. Huh? Distribution, yeah. And by that I mean that I could be a nurse and I want to do decision coaching with my patients. So for example, for dialysis. But maybe my colleague, the doctor, is not on board. Then it's very difficult to do this, right? So there has to be an agreement in the team that this is how we structure our involvement with the patient, our communication approach. And as I said, it can be from some subtasks, some steps of the decision-making process to making the entire decision with the patient. And we know that in many cases, especially when we talk about like big decisions, it is the physician who makes the final decision. And that is, of course, also okay. But in some cases, the nurse or the decision coach can make sub-steps or also make the final decision, because nurses actually make a lot of decisions with the patients as well. So it could look like this in some cases. The approach like this, that a patient has some complaints. Maybe he's hurting in the knee. He goes to the consultation with the clinician. In there, he gets the full package. He gets a diagnosis, information about the different options, the deliberation, and they make a decision. And the patient goes out on the other side with a treatment. But sometimes this can actually be a lot to bear for a patient. Sometimes they don't know why this decision was made. Maybe it was made without involvement also. And it can happen in a very fast time. And it can be a lot to bear actually for a patient. So then the question is, could there be an alternative approach? An alternative approach to involvement? And yes, there can, because we can use this coaching process. There, the patient has a complaint. He goes to the consultation with the clinician, and maybe it only lasts for 3 or 5 minutes, because he only gets information about the diagnosis, and then he goes to a session with a decision, a consultation with this. Why doesn't it jump on? It's a little, yeah, it should say consultation with a decision coach here, and there he meets a nurse. She's trained in decision coaching. And the nurse gives more information about the options, about information, deliberation, what is important for you in this situation. And the patient makes reflections, and maybe he also is more able to ask questions to the nurse, because he's not in the position to ask questions to the doctor because he has so little time. And then the patient goes out with the preferences in his suitcase and can meet, again, a consultation with the clinician to make the final decision. And then the patient can go the treatment, meet the treatment, and has actually made an informed decision, and is now happy to go this treatment, to undergo this treatment, and is sure of what the right choice was. So this kind of approach is pretty new, and they're not doing it in so many places. So we're trying to start implementing it in Norway now. It's approach used in Canada and in Germany in some trials we're going to mention a little bit later. So this is an alternative approach where you really have like the IP, the interprofessional shared decision-making approach. Jürgen?
May I add a little? Can you go back to the last picture where the big house was with a... Yeah, you mentioned the problem of the pure volume of information and the time frame, and I want to add that this also is a very difficult role for the clinician, because it's many roles. The physician would be the person making the diagnosis, an information provider, a coach, decision maker, to mention just a few of those roles, and would have, in such a consultation, would have the need to, to change the HUDs all the time. And this is very difficult. I know that from other contexts, it's already 2 roles is too much, but 4 or 5 does not work, and doesn't work for the patient either. So to split this, or even you would have much time and more than 3 or 5 or 7 minutes, but everything in one talk with so many roles is just confusing. So therefore, maybe split it up.
Okay. So, and I also wanted to say one more thing here, because I briefly want to mention a study done in Germany by colleagues of us and Jürgen also some years ago, where they implemented and they tested a decision coach training like this, also using this 6-step approach, and it went actually very well for a while. However, when the patient came with his preferences in the suitcase to see the clinicians were not trained, and then the clinicians were trained but were not always really on board in this approach. And that was a problem, because then the patient was so ready with his preferences, and the physician looked at the pictures and says, yeah, now I think this is the right decision for you. And then the patient was not able to say anything more, and all this good decision coaching was actually wasted. So it is important that the team is on board, and we also know from research that training whole teams has a very good value for implementing shared decision making. Okay, so why shared decision making? Why decision coaching? So decision coaching can help create an environment where patients can engage in their own healthcare and receive support to make these informed decisions with values, preferences, and treatment goals. And we recently conducted a Cochrane review about decision coaching with 28 randomized controlled trials with over 5,000 participants. And we had 17 studies on decision coaching, and they found that it improves the knowledge for patients, such as also patient decision aids use. We have another Cochrane review for that, and it helps prepare patients for decisions they're facing, and it didn't show any negative effects on patients. So that are some of the results from this Cochrane review. So, and I said it can be done in various ways, and there are some key elements within elements for decision coaching. So, as nurses, we often identify the person's need to make a decision. So that's one element. We support in understanding information about options, including benefits and harms. And probably many of you who are nurses here have experienced that patients come after they have talked to a physician. They come back to the nurse and say, oh, I got some information from a physician, but I didn't understand anything. Could you help me explain it one more time? I see a lot of you are nodding now. Yeah, so that happens a lot, right? So that is that's part of our skills as a nurse to do this. We provide patient information. Also, we can explore preferences related to the options, and we also meet patients and talk to them, have more time to talk to them, to pick up those cues I talked to you about earlier. So pick up cues, what is important for this individual patient. Additionally, we can prepare for the consultation with the physician if the final decision is made with the physician, and contribute to the implementation of the chosen option. So contribute and help the patient to go through with the treatment or the measure. So these are some important elements in decision coaching, and important elements that nurses already do, actually, but we just have to put them together with shared decision making and with decision coaching, and then we can get a more clear picture how we can actually conduct decision coaching. Important is also to know that we, of course, always should tailor this to the needs of the patient. Where is the patient now? What kind of information has he already received from the physician? And what are your needs? And that we are non-directive. So that means that we are not guiding the patient in one direction, but we are helping and facilitating an informed decision and a shared decision process. I told some of you maybe in the beginning that we have two different of these 6 steps cards, right? So in the 6-step card for the nurse, I'm going to give you a QR code later so you can download it. There we actually use some of these skills or elements in decision coaching, because we have some helplines here, so the decision coach can check the status of the decision. Where are you now? What is needed to implement the decision, or explore reflections and help consider. So we have like some helping lines here for the decision coach to use within a decision coaching session, but following the same 6 steps. So are there some comments here? Do you have somewhere in Korea like some medical domains where this works kind of already. I will mention in the first lesson we had when we came here, somebody said, I think dialysis or diabetes, that nurses were kind of like a decision coach. Does somebody want to comment on it? Jesus, do you want? You look like, yeah? Gibst du dein Mikrofon, Jürgen?
So you're talking about the decision, the aids that we watched in the video, right?
No, I was now I was
Oh,
like more in
hemodialysis
general.
team,
If
right.
if there's
Hemodialysis.
somewhere where you already like use kind of this approach. Or, yeah. Okay. Yes. There.
Yeah,
Yes.
yes. So some of the experimental team using the IPA model,
Yeah.
the nurses are playing the role as a decision coaching using decision aids.
Yeah.
So different types of informations. So then I think the two of the teams are here, I guess.
Okay. Other comments or questions? Do you want to say something? Mhm.
So in terms of the decision age, right? So yes, we develop the website for the patients. So, but in Korea in general, but especially in dentistry, there is very limited time for each patient. So as we call like 3 minutes consultation or something like that. So in this case, in dentistry, dental hygienists involve a lot during the consultation. So we develop some website with systematic reviews and all the evidence, and dental hygienists can also involve during the consultation also with the dentist. So dentists kind of explain all the diagnosis or the prognosis of the patient based on x-rays and all the indicators, and then we use the website with dental hygienists, and she or he explained more about the symptoms and pros and cons, and yes, those kind of things. I think it's very good. Also, we involve the patient's autonomy system in the website, so patients can actually check how much autonomy they have it in terms of making decisions. So that's the way the patient realize, oh, I'm the person who is quite independent for making decision or not. So that's the way the patient kind of realize that, oh, it is important me to involve the decision making process or something like this. So we very look forward to using in real practice so much. Thank you.
Very good. So you're already doing this actually, like they're acting as decision coaches. Yes, very good. Are there some other questions or comments?
It is a little bit complicated issue, so I wanna talk in Korean.
Yes, it's okay.
요즘 이제 점점 의사들의 책임이랄까요? 어떤 그런 법적인 책임. 근데 저기 지금 자막이 없는데 괜찮나요? 저기 원래 보셨던 것 같아가지고. 네. In these days, there is some complicated situation in Korea. There are many medical legal issues about the doctor's duty. So many patients complained about the unexpected outcomes from the every health issues. So in these days, some young doctors demonstrated, and they leave their work.
Yes.
Yes. So, and so if the decision coaching is delegated to the another healthcare professionals, then the medical legal issues can be concerned by doctors as well as nurses or like that. So that is my personal opinion, that the decision making in Korea is very complicated. So many nurses or some other paramedical persons cannot can endure that kind of medical legal problem. So I think there it can be, this system can be this system can be some relief from there is yeah. Then I can speak in Korean. So 그래서 그 우리나라에서는 그 다른 의사가 아닌 파라메디컬 혹은 널스들에게 이런 역할이 주어질 때는 어떤 법적인 보호 장치가 있어야 된다고 생각을 합니다. 그래서 그런 부분이 같이 이제 가야 된다고 생각을 하고요. 그래서 저희 팀 같은 경우에는 그 간호사들이 뉴트럴하게, it does not make sense, right?
Okay, the translation really doesn't make sense.
I'm sorry.
But okay, did I understand? I have to clarify some things. Did you say, are you afraid of the nurses or other healthcare professionals taking tasks from the doctor? Are you concerned for that? Yes, you're concerned for that.
Yeah. So in our team, the nurses give some very neutral information
Yes.
only.
Yeah, but that's also okay. Yeah, so this when I talk about decision coaching with physicians in Norway, physicians are always a little bit afraid that somebody will take their tasks, but they don't have the time to do all their tasks. So over time, they understand that we have to share, and they can share because nurses already do provide patient information. So actually, and patients already go to the nurses and ask, I didn't understand this information, or I need more information. Could you explain it again? So it's actually not such much new elements, but we have to work a little bit on it, how we do it and how we structure the consultations. So we don't want to take anything, we don't take any responsibility away from the doctors, because they're still legal requirements, and they're in charge of making most big medical decisions, of course.
This is a structural change. It's not starting at developing the decision coach and from that point starting up. It's of course it's a whole department that needs to become convinced about that this is a good solution, everybody, and then the structure changed, the information, the way the information goes, and the order of information provision is changed. And it's not without reason that there were you were talking about decision aids, because it's then quite feasible when there is a decision aid existing. We will also talk about a little more what this is, because this makes it easier for the nurse to give a standardized information. I've been within 2 decision coach trials developments. One was in multiple sclerosis, the DCIMS trial. where we developed whole centers, and of course specifically the nurse, but importantly we needed the agreement of the physicians, and we needed harmonized attitude about that this is really a decision the patient is supposed to make. And actually in the multiple sclerosis it didn't work so good, because the physicians would sabotage the whole thing and in a way fall the nurses in the back. And the nurses were in a way anticipating that, and they were not daring to take their role. This was interesting. Also many good things were in place, amongst others a good decision aid. The other trial, this POPEO trial, was in breast cancer, and there it worked, with exceptions, very well, and we had 50% more informed choices, and this is a lot. This is really a lot.
So to say that again, that when it was measured whether the patient made an informed decision in a randomized control trial, those who got the intervention, decision coaching, and the decision aid, 50% made an informed choice. In the control group, no informed choices. So it makes a big difference whether you use patient decision aid and decision coaches.
And more patient involvement. And then there was a process evaluation, and the nurses expressed they really liked that, and they liked themselves in this role. So they wanted to continue. And the process evaluation also showed that the biggest barriers they could identify were the attitude of the physicians. Not all of them, but there was a lot of work to do because of moving control over to a colleague which is not a physician and losing control. So they would have the last talk with the patient, and then maybe turn the whole process. And this, of course, would be good. But still, the quantitative results were very, very good. But I think it's not always applicable. It's applicable if you have very complex procedures around one problem. Like I mentioned, the multiple sclerosis decision-making about immunotherapy treatment. This is one. Or the treatment of a certain kind of breast cancer.
Or diabetes type 1. In Norway, there the physician makes the diagnosis, then the patient goes to diabetes nurse, and she explains the different options for treatment, and then the final decision is made either by the nurse or the physician. So I will go back to this picture one more time, because I agree that it's not right for every kind of decision where SDM is relevant, because sometimes it should be the doctor who makes the whole SDM process, but in some places it can be relevant. In some places, from giving information or doing some value clarification, like small steps of the decision-making process. And in some cases, also nurses make the entire decision. So this could be, we are actually now beginning data extraction today in a study where we look at the nurse's role in shared decision-making. And so breastfeeding or not, or what kind of bandage, or what kind of system for measuring blood sugar. So a lot of different medical problems where nurses also make the final decision, actually. Okay, so going a little bit further, well, we use this decision coaching. You could use the Ottawa Personal Decision Guide. I know that some of you know this already. It's a generic decision guide that can be used for any health-related or social decision, where there are multiple options available, and they discuss what decisions are they facing, what treatment options are available, and write in what the benefits and harms are of these options. So I know that you are going to translate and validate it in Korean soon, I think, and we have it in different languages already. This can be used with one a patient and healthcare provider, and there's also a version where it's a healthcare provider, a patient, and a child or relative. So there are two different versions. So this can be used to guide, but remember, here you have to fill in with evidence yourself. So it's not a patient decision aid, but a guide, a decision guide. Okay, was there one question? Come on. Yeah, good.
Regarding the already existing practice of decision nursing.
Yeah.
From the low risk children.
Okay, very good.
Thank you. Can I speak in Korean?
Yes.
저는 이제 종양내과를 하고 있고요. 조금 저희가 간호사 선생님이 아직은 SDM에 관련된 뭐 수가나 이런 프로세스는 정확하게 없지만 주로 이제 종양 전문 간호사 선생님들이 이제 항암 치료에 대한 이제 설명이나 이제 부작용에 대한 이게 교육 이런 것들을 주로 하고는 있는데요. 여기서 조금 저희가 이제 생각하는 SDM에서의 좀 더 올바른 역할이라고 하면 이제 저희는 대부분 다학제 진료라는 것을 통해서 처음 진단을 받습니다. 그러면 다학제 진료를 보고 나서 내가 캔서고 어떤 상황인지가 이해가 되고 그 이후에 종양내과 전문의를 만나서 항암 치료에 대한 이제 결정을 하게 되거든요. 그러면 그 사이에 당신이 진단 상태와 그리고 항암 치료가 어떤 옵션이 있고 그런 치료가 어떤 효과와 부작용을 갖고 있는지 저희가 디시전 에이드를 통해서 환자에게 자료를 줄 수 있을 것 같고요. 그런 자료를 주게 되면은 이제 환자가 다음 종양내과 전문의를 만나서 항암 치료에 대한 진료를 받기 전에 이제 그 종양내 전문 간호사, 그 코칭을 하시는 선생님은 환자가 그 내용을 얼마나 이해했는지 확인을 하는 겁니다. 정확하게 이해를 했는지 확인을 하고 그리고 환자의 또 프리퍼런스는 어떤 것을 또 생각을 했는지 이런 것들을 확인을 하고 그리고 특히 노인 환자분들 같은 경우는 암으로 인해서 돌아가실 확률도 있지만 본인이 갖고 있는 다른 코모비디티 때문에 이제 여러 가지 항암 치료에 대한 리스크나 또 기대 여명이 또 더 짧을 수도 있기 때문에 그러한 부분들을 저희가 이제 컴프레hen시브 제리아트릭 어세스먼트를 해야 된다라고 이제 얘기를 하고 있는데 그런 평가를 같이 하는 겁니다. 그러면은 이제 환자가 앞으로 갖고 되는 예후나 또 항암 치료에 대한 부작용이 얼마나 나타날지도 저희가 예측할 수 있는 그런 자료들이 있거든요. 그런 모델들이 있기 때문에 그러한 인포메이션을 가지고 의료진이 환자를 만나서 이제 의사결정, 항암 치료에 대한 결정을 하게 하면은 훨씬 더 이제 환자의 맞춤형 그리고 또 환자의 의사를 반영한 그런 치료 결정이 될 수 있을 거라고 생각을 하고 있거든요. 그래서 그런 식으로의 어떤 간호사 선생님이 코칭을 하는 그런 모델들을 우리나라에서는 좀 적용을 해볼 수 있으리라 예상이 됩니다.
Also, I didn't. Is there anybody who can give us a very short summing up? Difficult. I mean, it's fine without, but just is there something important we should know? Yeah.
Something about the struggle because of Korean nurses' role in the healthcare system. And you struggle to see how this could be applied. Is that correct? Did I capture it? No?
This is not my area, so I'm not sure how much. But then she's trying to do is it's not like we haven't established reimbursement system for what nurses do already yet. But then their field, and she's working in oncologist. She's an oncologist, and then in oncology field, and then we have a nurse practitioner who's specialized in oncology. So she's trying to kind of establish the collaboration between nurses and doctors, and nurses' role is to help patients understand what doctor already explained to the patient. And then also that is one side of the role. And then another role is to help patients, the nurses help patients to identify or express preference and needs as a way of preparing patient for the decision-making process. That's what she sees as a possibility.
Yes.
And that's what she's currently trying.
Very good.
Is that clear?
Thank you so much.
Thank you for
Thank you
sharing.
for contributing.
Very good. Okay. So now I'm going to talk a little bit about patient decision aid, just showing some examples, because as we have already discussed today, we know that using decision aids is important, especially for the quality of the information.
Simone,
Yes?
can I go over the details of the training of the decision coaching?
If I should go in to the details?
I'm a little bit interested.
You're interested, okay?
Yeah, I'm not gonna go up.
No, but I could say a little bit more if you would like that. Yeah.
This would be helpful for us.
Yeah, so I will take the example I did 2 weeks ago for the oncology nurses. They also get kind of the same training you receive now, with talking what is shared decision making, but even more about the nurse's role in shared decision making. So both more theoretical approach, but also more skills training. So in a few minutes, you're able to do a role play. And then the nurses here can choose to do decision coaching approach and apply that in the role play. So then you can try to use that approach based on this nursing card. And they also get training in information quality, because nurses often say that, oh, I don't have the information the patient need to make this decision. So in some cases, nurses actually don't have the information, and only based on what the patient says that the doctor has informed of, the nurses try to help with the deliberation and try to support in the places they can. But in other cases, they have patient decision aids, right? And that is a very important element when we do decision coaching. And the Cochrane review, if I didn't make it clear, I will make it clear now. Patients increased their knowledge about the options when decision coaching was used with evidence-based patient information, such as a decision aid. So that's very important. So that's why nurses also need to know something about quality of information, such as patient decision aids or patient information. Do you want to?
Another important element of this decision coach training is what is a didactic core element in all our training modules, and this is about trying it and delivering a sample of your communication to the trainers and receiving analysis-based feedback, individual feedback. So this is very effective. We have been able to show this also with physicians. It's very effective in short time for the trainees. They get a serious gain of competence. But this requires that they would deliver those recordings. And here's a kind of a challenge, and Simone had to experience that in her trial with decision coaching. Everything went fine during the training and with regard to the method she described now. But when it came to the recording, to be able to give the feedback, which is essential in our eyes to practice it, she wasn't lucky to get those videos because the participants had some barriers, and of course they claimed it was a time, and there were different things, very understandable things that were barriers, and but we were also discussing this critically, because we think actually that practicing shared decision making also requires attitudes of regarding being open for sharing your work, letting other people look into your work, not being afraid, being daring to make mistakes and showing this to others, being open for getting feedback, maybe negative feedback. But without this this sharing culture, it's difficult to learn. And how can I share, develop a sharing culture with the patient if I'm not sharing with my colleagues? So here's something to resolve.
And in studies, it's feasible to do it like this and give personal feedback to 20 nurses. But in real life, where I also work, it's not so feasible. So there we had to restructure some part of the training and look at other methods, how to provide them with the necessary skills. So, but it's a very important point to make. And the feedback, we know that giving feedback on own behavior, that is an evidence-based behavior change technique. So that's why we try to do it when we have the possibility. And I've also done it and documented in several trials. Okay, so now I said a little bit more about the decision coach training, and we can talk more about that if you're interested later also. So to patient decision aids, I know that most of you know what they are. They're intervention designed to support people to make health decisions. And at the minimum, patient decision aids make the decision explicit, provide evidence-based information about the options, the associated benefits, harms, and help clarify values, personal values, for features of the different options. So this is the IPTA's definitions. So they should provide reliable information and help motivate the patients to take part in decisions. And this is also an important part of decision aids. And they can be used before consultations, or others can be used after or during consultations. So we have some on our national health platform. I'm going to show you an example later. And they're often used before the consultations because they are pretty much text. So it's too much actually to use within a consultation, but a nurse can also use it before the consultation. And they present clear evidence-based information about the condition and the different options, of course. And as you probably know, there are many types of decision aids. This is Victor Montori, another guru in shared decision-making. So I borrowed these slides from him. Here they are using a paper-based decision aids regarding treatment of diabetes type 1. So that's possible. Some use like these cards in consultations, paper-based. And we have more encounter tools. These are some colleagues of ours. It's called the Share It decision aid. This, as you can see, it's maybe a little complex for a patient to use, but it's more an encounter tool for clinicians to use. But there are also some aspects of this with practical issues for patients they could go into with the consultation. And then to give you one example of how our decision aids in Norway look so far, this is breast cancer surgery. And the content here is actually pretty much aligned with those 6 steps we went on earlier. The patient gets mitt valg, it means my choice. So the patient gets some awareness of why should I participate and what is the choice between. And then we also have some movies of patients and clinicians in the decision aid. I thought I had more slides, but I didn't. So then about the mine muligheter, that's the options. So they can read about the options, benefit, harms, and so on. And also watch videos, and then they can, there's like my reflections section where they can do some reflection, also type in questions for the physicians. So there, as you can see, pretty much text and videos, so it takes a long time going through the whole decision aid. And this is the reason actually why we are also now developing a simpler decision aid app for patient application on the phone. So we're going to have different kinds of decision aids for patients on the national platform, but we are working nationally, so we don't develop decision aids in different formats for the same medical problem, because that would not be good. So we are collaborating. Okay, so now you are going to do some active exercise again to wake up a little bit. It sounds like somebody is working out on a treadmill or something here in the. Yeah.
I feel sorry for the people working in this shop around the corner. They must be crazy. Yeah, so we are good here.
Yeah.
But yeah, you already. Yeah.
Wieso was noch anderes?
No, it's about instructions, because I think when you build those groups now with 3 of you in a group, always 3 of you. Why 3? One is the health professional, the other one is the patient, and then there's the third person observing. And this third person observing, we would like to ask afterwards maybe some questions, how it went and what you observed, what was interesting. So this third person should be prepared to maybe report a little from if you want to.
And the observer can use the map-in observer sheet for observation if you want to, because you have 1 more left. So divide into groups where one is the healthcare professional, physician or nurse as a decision coach, and then 1 observer. And then you choose a medical problem. And it doesn't have to be something you know a lot about. You can just make fictive numbers if you want and play a little around just to get the feeling.
Improvise.
Yes.
Yeah, it's more about the structure than about the specific medical knowledge.
And
but be clear between you. Be clear about the setting and the very problem. What is it? Which condition? At which stage? What is the situation? This makes it much easier. And then you try how long?
We will give them some time. So we will see how it goes.
More than 2
More
minutes.
than 2 minutes, yes. Now you really have the time. And you can use this 6-step card you have. And if somebody would like the nursing card, we also have it, the QR code. Let me see. Here. This is the adapted version for nurses using the same approach.
Mm-hmm. And you can move a little. You can move your chairs to have a good setting to hear each other, not so much of the others.
Are there any questions? We will go a little bit around. Okay. Now we have to. I'm very interested how the observations went. So I will ask 1 more minute. Okay. 1 more minute. 5 more minutes. 3.5 more minutes. Okay, just finish up a little bit longer. Okay, now it's time, because time is running fast today. So, I am eager to hear from some of the observers and from some clinicians. Maybe I will start here. Okay, are you ready to listen?
Yeah.
Were you an observer?
We have 2 scenarios.
Okay.
Chiju and breast cancer. So which one would you like to listen?
Breast cancer, please.
Yeah, would you mind using the Korean?
That's okay.
Okay. 그러면 시작해 볼까요? 그 환자분께서는 오늘 그 브레스트 캔서로 그렇게 내원하시게 되었는데요. 그래서 지난주에 그 검사 결과를 토대로 한번 설명해드리고 보고자 합니다. 그래서 일단은 그 환자분께서는 지금 그 브레스트 캔서 스테이지 3로 이렇게 판정되었습니다. 네, 그래서 지금 치료 결정은 진행하셔야 될 것 같습니다. 그러면 그 치료 결정에 앞서서 지금 환자분께서 혹시 어떤 원하는 그런 치료에 대한 기대가 어떤 것이 있는지 알 수 있나요? Observer?
Yes, was he the observer?
Oh, no.
No,
I've
you were
been
the.
active
But that's okay. Share your experience. Share your experience. How was it to go through those steps? Did it felt naturally?
naturally.
Yes. How
yeah.
was it? Just say a few
Also,
words. How it was it to go through those
그럼
steps?
안 느꼈는지 그럼 observation 한국어로 할게요. In Korea? Yeah. 그럼 제가 그 두 번째 케이스에서 그 치주 질환에 대해서 그 observation 했을 때 두 가지 느낌점이 있었는데요. 한 가지는 바로 그 의료진이 뭔가 그 치료 옵션을 제공했을 때 권유 같은 느낌 혹은 그 이렇게 share decision making의 과정이 충분하지 않다는 그 감각이 느꼈고요. 그리고 두 번째는 뭔가 그 환자가 자기의 그 목표를 아니면 환자가 자기의 그런 선호 프레퍼런스를 표현하는 데 있어서 뭔가 어려움도 있는 걸로 지금 좀 느꼈습니다.
Okay, so I cannot comment on that. But do you would say something? Very short.
I just interpret a little bit if you
Yes.
for your better
Yes.
understanding. So he's explaining something that there are some moments that he felt SDM was not enough for implementing. So the first was the patient's preference. So patient's preference were not adopted 100% in the situation. And the second was the recommendation. So even though we presented the option in these 6 steps or listing all the options, but at some point he felt that clinician kind of recommended rather than presenting it.
Yeah.
So he felt those kind of feeling during the SDM observation.
Okay.
Yes.
Okay. Thank you. Okay, I will ask one more here. Who was the observer here? Did you have some? Yeah. Do you want to say a little bit of how it was to be observing?
Okay, yeah,
Not so long. Little short.
okay. The interesting point in our session is that, the physician, she's so giving a lot of emotional support for the patients, the suffering. So she's, and then she's talking about the possible options, which is about palliative care, which is new and which is kind of a challenging option for the patient. But she's, explaining why it could be your option and it might be relevant to you. And she explained very well. And then, move to what it looked like and what's the difference between the, the general, the chemotherapy, something like that. So she's giving some time to make some trust with the patients. Yeah, as well as just, the treatment options. That's very impressive point. And then, our patients doing very well in expressing his preference, something like that. He's worrying about the cost will be needed for the care. And he's also talking about maybe he might change his mind. So the physician say you can do some, you can change your mind, so take some time. Maybe in the middle of a treatment, you might say something about your preference. It's possible. Yeah, so that's kind of it's like a 6-step model, but it's also like it could be circle, repeating again. Yeah, that's what she's doing very well. Yeah, so very good job, I think.
Thank you so much. Thank you so much. And then because you are a physician, right? And yes, and you work with palliative care, where shared decision making is very relevant. And when we talked in the break, you said that you need more awareness and they need more training. So how did you feel it was to be trained in the 6 steps? And does it feel naturally for you? Or is there something new here or special?
Okay. I'm actually used to these steps. Yeah, but I never mind of it. Yeah, because I used to be educated in palliative care field, and when I listened to today's lecture, it's the same step. Yes, so it was not difficult. It was natural communication, which I did in my field. But as I told our team members and you before. Most of the clinicians, they are not interested in these kind of communication. They have very little, what is it? interest in about the process. They are very urgent. They have no time. They want to go directly to the result, and they want to decide quickly. So I think we should educate more, especially to the medical and nursing school students, to have better awareness all around the medical field. Yeah.
Thank you so much. That's and it's nice to hear that you felt that these steps feel natural to you and that you already do it. And many physicians say that, and we know that they actually do those steps, but there's always room for improvement, right? Yeah. Okay.
Maybe one other voice. Maybe on the question, was there something you were surprised about?
Was there something that you were surprised about when you went
when trying
this role play?
Yeah.
Do you want to talk about it? Okay.
Thank you. Our case was a perimenopausal woman in her early 50s with uterine leiomyoma, and usually there are a multitude of choices, and the physician started explaining these choices, but the patient had a lot of questions. So, and then as a result, the invitation to participate in the decision-making process, the key message, it actually came a lot later in the interview, after the physician went over the benefits and harms. So that was something that was a little surprising about our case.
Thank you. Good. I think we nearly have to.
Yes, we have to go on.
Also, you gave each other what was supposed to be given. We have not been able to support in this role plays, but we saw you working, and we get an idea that you really use the time good. We go further.
And the observers can also give their feedback sheet to the healthcare professionals if they want. Then they can read a little bit about that later. So then, just to wrap up, as I said, I do a lot of clinicians training, and I also do train-the-trainer courses to train clinicians to give this kind of training in their hospital trusts. And there I had the exercise some months ago where I asked the clinicians, so how would you convince your colleagues to do shared decision-making? And they thought about it for a long time. And then I took this picture and got this answer from one of our oncologists, Frode. And he wanted to go home and ask his colleague, what if you had started a treatment and afterwards found out that there were several other options available? So this was his best suggestion to make his colleagues do more shared decision-making. And I love this picture of two good colleagues on a communication training, like you today. Okay, with this, we are now ending this basic shared decision-making course to say that patients should be given the opportunity to make informed decisions. Of course, this requires good information based on a good communication approach, patient decision aids, and so on. It should be up to date and complete, and of course presented in a comprehensible way. And shared decision-making and decision coaching can be supported through various methods and tools. And so that's some of the summary from this session, and this training is based on several studies. So now we